Type 2 inflammation inhibiting systemic treatments for atopic dermatitis offer more targeted therapy for patients whose disease is not adequately controlled by topical treatment. In this two-part special episode of Beyond the Headlines, Doctors George Martin and Eric Simpson and nurse practitioner Lakshmi Aldrich provide an overview of atopic dermatitis pathogenesis and share recommendations for appropriate utilization of systemic therapies. Part 1 focuses on the pathogenesis of AD, the comorbidities associated with this condition, AD's impact on patients' quality of life, and when to consider systemic therapy for AD.
Greetings. I'm Dr. George Martin, a medical dermatologist from Maui, and today I'd like to host this podcast, and joining me will be Dr. Eric Simpson and nurse practitioner extraordinaire Lakshmi Aldrich. Both hail from Oregon, and I'd like them to tell me a little bit about themselves. Lakshmi?
Hi, George. I'm delighted to be a part of this podcast. I'm from Portland, Oregon, and I've been practicing medical dermatology for the past 24 years, and I'm delighted to be talking about atopic dermatitis, a subject that's near and dear to my heart since I've been not only a provider, but a patient for many years. So looking forward to our discussion.
And Eric?
Yeah, hi. I'm upset, Lakshmi. I think you got me by 2 years. I always say 20 years now that I've been practicing dermatology, and practice is just that. Some people call me an atopic dermatologist, but I do more than just atopic dermatitis, skin cancer and whatnot. So no, it's a joy to be here with you, George, to talk about my favorite topic.
So now I'm going to pick your brain, and you've got a patient in front of you who clearly has horrible AD, and that could span the range from an infant all the way up to an adult. And that patient's sitting in front of you. And now we have basically two classes of drugs. We have the biologics, and currently we have the approved dupilumab, and we have tralokinumab, and now most recently we have lebrikizumab. And then as far as oral systemics, we have the JAK inhibitors, abrocitinib and upadacitinib, two different classes of drugs with two different considerations. When you have that patient in front of you, and you're thinking biologic or JAK, Lakshmi, tell me what goes through your mind as you sit down in front of that patient. And let's pick a sweet spot. Let's pick a 22-year-old individual with really bad AD who, and let's start there. And then we'll go through some age considerations later. But let's pick that sweet spot with a bad AD with maybe some asthma, and they're sitting in front of you. They're otherwise very healthy. Talk to me about biologic versus JAK.
Yeah, I think it's lovely that we have the option now with 3 biologics that are available. And for me, it's a really easy place to start with dupilumab. It's been around the longest, has an indication down to 6 months of age, really nice safety and efficacy data, as well as the indications for some of those other comorbidities that we see with atopic dermatitis, including asthma. So I think it's a really easy conversation to introduce that. We have a lot of rich long-term safety data. I think that's what patients are most concerned about. If I have a young woman there sitting in front of me, she may have concerns about, is this going to interact with other medications that they're taking? What about family planning? I think that the ability to reassure these patients about how quickly they can see resolution and how effectively they can be moving to their next quality of life impact, I think it's a really easy discussion. I do talk a little bit about, again, with the long-term usage of Dupi that we've had, there are some safety concerns that we talk about. I do talk about primarily the eye inflammation that can occur, but I do mention that almost a third of patients who have atopic dermatitis, moderate to severe, may already have baseline eye symptoms. But if that is an issue, that may move me to a different drug. But I think Dupi is really the place that I like to start.
And so talk to me a little bit about how tralokinumab and lebrikizumab sitting in your refrigerator come into that discussion.
So I think that, Because Dupy was the first drug out of the gate, it has the most comfort level for me. But I certainly have had patients who Dupy has, I've got two groups. Dupy works great for a while, and then they start to see some loss of response. And they say, hey, I really, I feel like my itch is getting worse. I'm having to use my topicals a little bit more. Is there anything new that I have? Or I don't want to go back to the state that I was in. And so that's where I can really offer them Trelo or even Lebri, both great drugs, both highly efficacious. So I really have no issues with offering either of those drugs as a secondary source. If some patients have, I will say I might move them to Trelo first if they have more severe comorbidities, including joint symptoms. Very rare side effect of dupilumab. We've seen a little bit of arthritis in a segment of AD patients. I might start them with Trelo or Lebri in that case. But really, if they're doing well on dupilumab, but they're starting to have to use topicals more, they're noticing that they're getting up at night from itch, I'm going to move them pretty comfortably to either Trelo or Lebri.
Eric, lend me your thoughts. Patients in front of you, severe disease, moderate to severe disease, and you're thinking systemic. What goes through your mind?
Usually what goes through, I don't have an agenda. Like I don't think my goal is to get them on a drug. That's just where, just from a Zen starting point. And I have a whiteboard for each room, and I just draw quadrants, like do a cross through the middle. And I just tell them about, I want to get them into a category if they want to treat their eczema, which usually they do. And if they don't, I tell them then the risks of not treating are this, and that. So in my quadrants, I have phototherapy, I have traditional immunosuppressants, I have JAK inhibitors, and I have biologics. And I just kind of go in general about each from a, kind of 30,000 foot view. So, phototherapy, we'll talk about convenience, and I'll say about 40% reduction. Traditional immunosuppressants, I say these are studied in eczema. I can use them perfectly safely with you. And they can reduce eczema anywhere between, depending on the dose, blah, blah, blah. But the only reason to go here, because they're not FDA approved and they haven't been studying a huge population, is just cost. That's the only reason I'm even talking to you about this, is cost. Then I said, now we have a new generation, and then I'll talk about biologics as a group. And the FDA, the wording of the JAK inhibitor indication, they do suggest that you should use another systemic first, and they imply that biologics are in that list. And so I will kind of relay that and here's the reason why. But we also have the JAK inhibitor group, and we have two drugs, and at high dose they can beat any of the biologics in efficacy. Or in effectiveness, or whatever word I need to use for that patient. And so I talk about categories, and then I let a patient pick a category, and then we start delving into the different options in that category. But biologics, I think that's the workhorse of atopic dermatitis therapy. They don't need monitoring. They affect other comorbidities in a positive way. And so you can just kind of, so that, no baseline labs, no follow-up labs. So it is a kind of a nice category to start in. And then the nuances will be, which one do you start? And then do you switch within a class, or do you move out of a class? And I don't think there's right answers, actually. I think all of those are completely viable options. You might say, like to Lakshi, Dupy didn't work, or it lost its effect. Do I primary failure, secondary failure? Do I stay in the same class? Do I do Trelo then? And there are data coming out where there's not a wrong answer. You may lose a side effect and get better effect with Trelo, or you might gain a side effect and not have as good of efficacy. It's kind of a crapshoot when you're talking about switching. And so that's another discussion with a patient. Like, if you haven't had any results in 4 months, do you want to wait for another drug that's going to take a while, or are you now moving to a JAK inhibitor or something like that? So these are the complications of dermatology and of medicine in general. And I think patients can guide you. So use their knowledge in terms of what they're looking for and what they're willing to accept.
So when you're in the room with a patient and you've got three biologics, Dupi, Trelo, and Lebri sitting in your fridge, what is the nuanced discussion, particularly say, we're talking about, say, a 22-year-old, like a sweet spot with no comorbidities. Is there anything that goes through your mind as you think about all three? Or it's a jump ball?
Well, so patient preference studies have shown that efficacy and safety are the most important things. And so I think I mean, with Dupi, with 1 million people treated globally, it's been, approved down to 6 months of age, some approvals and comorbidities. That's a hard one to not start with from a patient perspective. And then with with network meta-analyses showing, and just multiple phase 3 studies showing that, probably the efficacy is a little bit better in Dupi than in tralokinumab, for example. But if a patient is, their conjunctivitis is their most important adverse event that they are worried about, and they don't mind 2 shots per time versus 1 shot, then there's a lower conjunctivitis rate apparent, that's apparent from studies and real world studies in Trelo. And so if that's their number one concern, then Trelo is the right drug for them. But they're all, I mean, I tell my patient, you throw a dart and any of them are going to be appropriate for you.
Lakshi, your final thought on the three? Is it a jump ball, or are we nuancing this?
Yeah, I agree with Eric. I think that all three of them have, great efficacy. And I think truly it's whatever we can get in the hands of the patients. So there are some factors that we have to consider, especially if the patient is not insured, underinsured. Some people, such as myself at the VA, we don't have samples in the refrigerator that we can start patients on. So sometimes I have heard providers say, "Hey, I will start them and give them a shot right then and there with whatever sample I happen to have." But if you are in a practice where you don't get samples, or in the real world, perhaps outside of the U.S. where that's not an option sometimes, it's really however we can get any of those drugs to our patient. I think that we can't go wrong with that. So I think there's things to consider: cost, insurance, ability for them to get it. And something else we don't always think about is their housing situation. Are they able to store the drug? Are they able to give themselves the drug? Are these people who are, young college kids who are traveling all over the place? Are there patients who are, and I've had this situation, who were former IV drug users and who cannot give themselves a shot for fear of triggering something else. So they need to come in and have somebody give them their shot. So a lot of things to think about, but really to me, all three of these are great drugs. That's a wonderful, wonderful place for us to be in as practitioners. So to me, it's whichever drug I can get for the patient that fits with their lifestyle and is going to work for them.
Patients over 50, and they've got either, like, you take their history and you realize they really were an atopic dermatitis their whole life, but now they're blowing up. And how are you approaching the 55-year-old individual who comes in and they're claiming it's their soap, their laundry detergent, their medication, maybe they're on losartan, and they think it's a drug reaction, and their GP sent them in thinking it's a drug reaction, it's an allergy reaction, and you've done the patch testing, you've taken them off their meds, and you've come to the realization this is atopic dermatitis. How do you approach that patient with our current biologics and JAKs? And Lakshi, I'll start with you.
Yeah, I think it's the same discussion. I don't think it's a lot different. The only thing that might be an issue is, again, other comorbidities. Obviously, as we get older, we might have other health issues that may play a role in what we choose. So if I have a 55-year-old who perhaps has been a smoker, who has a higher risk for potentially developing clots or some other things that maybe make me a little bit more nervous about starting them on a JAK, that would certainly play a role where I would be more encouraged to put them on a biologic. Again, if they're undergoing cancer treatment or are immunosuppressed in another way, that might be a different issue to consider. So those kinds of things would, the comorbidities later in life play a role in what I might recommend. But again, the biologics have, either the biologics or JAKs would be a great option. considering lifestyle impact and ability to give themselves shots, their comfort level with that. But again, we're in a great spot where we have wonderful treatments that are safe and efficacious, and we're not worried about, the other thing with biologics is no lab monitoring versus JAKs. We might want to be considering that might be an issue for some patients if they come from a great distance or have a lot of copays with additional labs. So that might be a factor as well. So I think that it's pretty much the same discussion, but in consideration of other aspects of their life later in age.
Eric, give me your thoughts about this adult patient onset or just, had AD all his life and now comes in just blowing up.
Right. So the only difference I would have from your history, George, is I wouldn't stop the medications normally. And so, we went back and reviewed chart reviews of these kind of eczemas of new onset in older patients. It was over 60. And basically, like so many of the pathologists said, drug reaction, there's EOs in there. And so then we looked at what were the results of drug cessation trials, where you step through systematically, and basically not one person's eruption resolved with drug cessation. And there was like 7 ER visits out of 80 people or something, because of cardiac issues when you start trying to switch drugs and or stop drugs. So I'm very skeptical about any kind of eczematous drug eruptions that are happening for many, many months. And I'm just like Lakshi, I go through the same situation. I go through the same discussion, and I do the shared decision making. And then you, if they have comorbidities, which is more likely, then you couch the safety with that individual. But I have 70-year-olds with comorbidities who are on JAKs, and so it's really patient dependent what their risk aversion is, what they're looking for, their goals, etc.
And then, so as we wrap up this discussion about biologics and JAKs, and particularly with focus, I just want to shift the focus back to biologic agents. Now we have an embarrassment of riches. We have 3 incredible molecules in play. Share some of the pearls that your takeaway pearls for our listeners about how you approach the 3 biologics in play. As you have a patient before you, or say you have a new healthcare provider in dermatology who is really trying to learn the ropes of your approaches to the 3 biologic agents. And so can you share a couple pearls with us, Lakshi, if you were counseling a new healthcare provider on the use of biologics in atopic dermatitis, and a pearl that you would share with your patient about these molecules?
Sure. I think that I would tell a new provider looking to start their patients on biologic therapy that all 3 of these drugs are highly efficacious, safe, and have long-term studies that show that the efficacy improves over time. So one thing is give these drugs some time to work, but give them a clear expectation. 3 months is a good kind of a sweet spot, in my opinion, to check in. If a patient is, saying after 6 weeks they're having absolutely no response to dupilumab, there's something going on, and you should then consider moving them. But most of these drugs are quick to work. But you do need to follow up with your patients, make sure they're taking it effectively. The number one questions that patients have after starting any of these biologic agents is, do I need to stay on this drug? And so this is a comment for both new providers and patients, is that this is long-term therapy. You have a condition. We wouldn't stop and start your high blood pressure medicine, and we need to think about your eczema in the same way. This is something that is keeping your system in homeostasis at a nice even level, and you need to stay on it until perhaps we have a different treatment that gives you a better long-term response with less injections. But in the meantime, these biologic treatments are meant to be long-term. That should be the expectation. We do also need to think about and have the discussion both with providers and patients about the reality of flares. You can be on any 3 of these drugs working really well, but you will flare, or you could flare. That doesn't mean necessarily it's a treatment failure, but You also really want to be able to tease out whether this is a flare due to something that's going on, or if this is a treatment failure. And there needs to be some level of comfort in knowing when to change a patient. So, and I think that comes with time, and it also comes with, as Eric mentioned, shared decision making and talking to your patients.
Eric, give us a few pearls about your approach to biologic agents in your AD patient.
Yeah, no, that was spoken like a experienced clinician for sure. It's hard to teach experience like that, but thank you for that, Lakshmi. Mine's really similar, actually. If the new clinician is having trouble, maybe getting patients on, there have a lot of patients who are concerned about going to the next level. Let's say, I think if they can understand, ask them what their disease, what their understanding of the disease is and why they have it. And so I think recognizing that patients are looking for the cause and looking for what they can remove or change to then bring them satisfaction and make the disease go away. They won't say that necessarily, but once you start probing, you recognize that that's what they're looking for. And so there's a grieving process once they realize, and once you help them through this, that it's a chronic disease that they're always going to have that we can't cure. That's tough. And you're like the fourth dermatologist I've seen. No one's ever said that. So you're the jerk at the beginning, but you're the one that's being truthful. But then once that acceptance happens, Kleenex for tears and etc., then we're going to move together as a team to get your life back in a safe way. And so that's the really exciting part, is that we actually have drugs that can do that in a safe way. For the biologics, I would say, any of them are going to be adequate. They're all doing very similar things. So that'll be between you and what you feel right about in terms of the efficacy versus the safety. And that's really clearance of eczema, clearance of itch versus conjunctivitis, really. And then and you mentioned for parents and patients, what I would recommend is, if they're reluctant about treating and they keep saying, well, they're not I don't want to go on a biologic, but they're not sleeping. Do you have anything for the itch? You have to then, couch that conversation of what the risks are of not treating the disease. And the risks are what Lakshmi was just talking about, is long-term sleep loss, development, comorbidities, and family disruption. And so you always balance the risks of treating versus the risks of not treating. And I think mentioning that in that way is helpful for parents to move forward.
So I've been mentored by some of the greats in atopic dermatitis, and you listen to how they approach the patient. And so when it comes to patients and we sit down on the stool, we get at eye level, the first thing out of my mouth is like, how you doing? And let the patient tell you their story. And when they tell you their story, two things I focus on. I said, well, let's take a look at your skin right now. And they're already in a gown. They have their underwear. Don't look at them just with their clothes on. You want to look at all of them and see where they're scratching. Could be a butt crack. It could be a scrotum or a vulvar area. Make sure your nurse is in the room, particularly guys when you have women there. Look at their scalp and see where they're itching. And so with that, then the discussion is, how many shots of cortisone or pills of cortisone have you received? And what kind of cortisone are you using? And when you start to hear their story about their cortisone use, I look them in the eye and I say, look, that's not working. If you needed this many dose packs and this many shots, it's clear to me they're not working. And by the way, did you know that of all the therapies I'm thinking about that would benefit you, that steroids are the most immunosuppressive and potentially harmful to your body when used long term? And there's this eye-opening, there's this awakening, like, oh my gosh, no, we have something for you, whether it's a biologic agent or a JAK inhibitor. Let's have that discussion right now. As far as other healthcare providers, as we sort of coach them up, and I've had medical students and residents, as we all have, and new nurse practitioners and PAs. And we see that patient come in from the community. And we say, they've received how many shots of cortisone, how many dose packs? What is this telling you about the efficacy of steroids? Which to me is the number one impediment to getting these patients on really good therapies, biologic agents, JAK inhibitors. And so that history of steroid use, and in many cases abuse, is really critical to the decision making, both with the patient and as we, as clinicians of experience, mentor other clinicians. It's getting that steroid history, because again, that is the biggest impediment to an improved quality of life. And I think that's it. Whether we use a JAK or whether we use a biologic, we have command of those drugs and realize their incredible safety and where we can nuance their use. But again, the steroid is we're getting to an age right now where we don't say ban the steroid. We want to just steward it in the appropriate way. And in some cases, it should be a one and done, right? And in certain patients.
I think we're kind of, as I mentioned, in a golden age. We have revisions of important guidelines, both within the dermatology area and the larger comprehensive group of providers and stakeholders who care for our patients with asthma, allergy, and other comorbidities. So these guidelines really do help guide us and our decision making, but ultimately it is the patient sitting in front of us and us taking the time to listen to their story, listen to their journey. And then I feel like our obligation is to provide fair and balanced discussions about all of the treatment options that are available to them. I love Eric's idea of that whiteboard where we draw out in a very simplistic way for our patients all of the options and how they can benefit them in their journey, reinforcing that we're going to be a partner with them for the long term for this chronic management. And very specifically about the biologic treatment landscape that we have, very reassuring data on efficacy, safety, long-term use, even in our children, pediatric population, as well as in our young women of childbearing age, and as well as our young men who are considering starting families.
Yeah, no, I think that was beautiful from Lakshi, and it may sound like, and I agree completely. It may sound like it takes time, to go through the options, to hear the story, to understand how many prednisone doses they've had over the past year. It all takes time, but that investment early on is worth it, and it really pays off. And it'll make you the hero. So you be where the buck stops. They're not, don't go doctor shopping. They're not going to go back to Zoom care for another prednisone. You're the hero because that's where the buck stops. That's where they get treated appropriately. It may take a little bit more of your time, but after that, it's very easy appointments after that. And the love of medicine and the reason why you went into medicine is there again, because you get to see the impact it can have on their lives. So it's good for you too.
Well, I want to thank you both for sharing your collective wisdom on systemic treatments for atopic dermatitis. As I travel globally, we have an embarrassment of riches with our biologic agents and our JAK inhibitors. And based on our discussion today, we realize just how amazingly effective and safe they are when used in the appropriate patient. And so again, thank you both for joining us on this podcast.
The overarching message for atopic dermatitis patients and the providers who treat them is that this is a golden age. There are more safe and effective treatment choices than ever before, and new guidelines on how to best use these therapies. Thanks for listening to this episode of Beyond the Headlines, which was sponsored by Leo Pharma.